Let's talk about neurotube defects. Neurotube development occurs around 3 to 4 weeks after fertilization. To produce a defect, external influence must be present during the first 28 days of development. Anencephaly, 2.5 out of 10,000 live births, stillbirth or terminations, 1/5 of which are live births. Spina bifida, 4.5 out of 10,000 live births, stillbirth or terminations. Etiology, anti-epileptic medication associated with neurotube defects, carbamazepine and valproic acid. It's up to 20 times the risk. Valproic acid is 20 times the risk. Maternal hyperthermia, fever, sauna, hot tubs, pregestational diabetes, maternal obesity is 3 times risk if BMI is greater than 38. Hispanics, people from Shanxi province in China has the world's highest NTD rate. Chromosomal abnormalities, 13, 18, triploidy, 22q11 deletion, Waardenburg syndrome, prior child with NTD, 10% risk if 2 prior child with NTD, 3% risk if prior 1 child with NTD. Consequences, polyhydramnios as a result of impaired fetal swallowing, especially with anencephaly, higher level of spinal lesions and encephaly, breech at term is another consequence. Patients with motor level dysfunction at less than L4 have a better physical function. Myelomeningocele has lower urinary tract dysfunction. Myelomeningocele, 40% would develop renal dysfunction. 75% of infants survive to early adulthood with medical or surgical management. Shunting needed in most infants with spinal bifida or ventriculomegaly. 1/3 of patients with NTD have severe allergy to latex. That's random. Folic acid, lower plasma level of vitamin B found in maternal plasma of fetus with NTD. It should begin 1 month prior to pregnancy until 12 weeks. High risk should take 4 milligrams. Who are the high risk pregnancies? Previous pregnancy, affected with NTD, partner or self with NTD, 3 months prior until 12 weeks. It can reduce the risk as much as 70%. Not prevented by folic acid. 30% of NTD is not protected by folic acid, such as poor glycemic controlled parents, moms. Obesity, valproate is associated with folate resistant NTD. Patients on anti-epileptic medication is not recommended to have higher dose of folic supplements. Vitamin A vitamin A is teratogenic. Should take less than 5,000 international units a day. MSNAFP secreted by fetal yolk sac and liver. High level then drops between 15 to 18 weeks. 2.5 times multiple of mean is 80% detection rate for open neural tube defect, 95% detection rate for anencephaly, with a false positive rate of 2%. Other reasons for elevated AFP: multiple gestation, fetal abdominal wall defects, fetal nephrosis, fetal demise, placental conditions. It cannot detect any closed neural tube defects. Second trimester ultrasound is better at detection of neural tube defects than AFP. It's 95% detection rate of NTD compared to 80%. AFP is still useful for screening for other abnormalities and placental complications. Abdominal wall defects, nephrosis. No additional diagnostic testing is needed if positive. Second trimester ultrasound for NTD. We can use acetylcholine esterase in amnio for diagnosis of open versus neural tube defects. Associated findings of open spina bifida, abnormal skull shape, such as the lemon sign, abnormal cerebellum and posterior fossa, the banana sign, ventriculomegaly. MRI can be helpful. Fetal echo should be offered if there's a suspicious for NTD. Fetal spinal bifida is not an increased risk of placental insufficiency. No data to support routine antenatal tests, antenatal fetal surveillance. Delivery at term is preferred. If in utero surgery was performed, risk of rupture similar to classical C-section. No adversely affected neonatal outcome with meningomyelocele with vaginal delivery. In utero spinal bifida repair has shown to decrease neonatal death and the need for shunt placement. However, there is increased OB and obstetric and maternal risks.